You know, when you picture heart failure, you usually imagine, like, a plumbing problem, a blocked pipe, a clot, a classic heart attack. It feels entirely mechanical.
Right. Very structural.
Yeah, but then you look at the clinical notes for inflammatory heart disease, and suddenly, we aren't talking about blocked pipes anymore. We are looking at a battlefield where the heart is literally under siege, and it's happening in two completely different ways. I'm your host, and welcome to today's deep dive.
And I'm so glad to be here for this one. It is the absolute definition of a diagnostic trap. I mean, we are looking at two diseases that sound like twins but operate in entirely different biological universes.
And that's exactly what we're going to unpack today using a stack of medical notes, historical texts, and diagnostic criteria. Because right out of the gate, we run into two medical terms that sound like they should be the exact same thing, just, located a few millimeters apart: endocarditis and pericarditis.
Yeah, they both end in itis, which tells us we're dealing with inflammation, and both affect the heart.
Right, but assuming these two diseases operate by the same mechanism just because they share a suffix is a huge mistake.
Oh, it's a mistake that can cost a patient their life. We're going to explore how the heart's tissue becomes a battleground in two wildly distinct ways. One is a structural, high-pressure bacterial invasion on the inside.
Wow, okay.
And the other is a low-pressure reactive fluid swell on the outside.
Okay, let's unpack this. Before we even touch on how doctors treat these, we have to understand the physical architecture of where they happen. In the past, people have compared the heart to a house, but reading through the pathophysiology here, that feels a bit clunky.
Yeah, houses don't pump.
Exactly. Let's use an engine.
Yeah.
If I'm grasping this correctly, endocarditis is like getting corrosive grit inside the engine, actively chewing up the internal pistons and valves.
That's a great way to visualize it.
But pericarditis is more like the engine's protective outer casing filling with fluid and overheating, basically squeezing the whole engine from the outside in. Is it truly that black and white, like an internal infection versus an external inflammation?
The engine metaphor works perfectly because it highlights the mechanical consequences of both diseases. Let's look at the inside job first, endocarditis. That is inflammation of the endocardium, which is the delicate endothelial lining inside the heart's chambers and valves.
The inside layer.
Right. And in clinical practice, when a doctor says endocarditis, they're almost always using shorthand for infective endocarditis. It is a bloodstream infection.
Mm-hmm.
Bacteria land on an internal surface, almost always a high-pressure valves, and they build what's called a vegetation.
A vegetation, which, it sounds benign, like a houseplant.
It does, yeah.
But the notes describe it as a mass of platelets, fibrin, and microorganisms. It's essentially a biological beaver dam.
A very destructive beaver dam. It's a living, growing colony of bacteria that either physically eats through the valve tissue, destroying the engine's internal seals, or it fractures.
Oh, meaning it breaks apart.
Exactly. It shoots infected, clot-like debris out into the rest of the body's circulation. Now contrast that with pericarditis. This is inflammation of the pericardium, that double-layered sac surrounding the heart.
The casing around the engine.
Yes, which normally just holds a thin film of lubricating fluid so the heart can beat without friction. Crucially, this is not a bacterial colony.
So it's not a bug chewing on the sac?
Usually, no. It's mostly viral, or what we call idiopathic, meaning the trigger is likely a virus that the lab just, couldn't confirm.
Got it.
It's a reactive inflammation to an immune trigger. It is not an active bacterial growth destroying tissue.
That feels like the massive first principles concept we have to nail down right away. Itis simply means inflammation, but it does not mean the same mechanism is happening everywhere in the body.
Not at all.
Endocarditis is an active, destructive infection on the inside. Pericarditis is a reactive, swollen inflammation on the outside.
And that distinction changes everything about how you diagnose and treat them.
So let's zoom in on that internal destruction. Endocarditis. I keep getting hung up on the physics of this. How does a single microscopic bacterium actually stick to a moving, slamming, high-pressure heart valve?
It's crazy to think about, right?
It seems like it would just get instantly washed away by the sheer force of the blood flow.
Mechanically, it absolutely should get washed away. For a vegetation to form, you need 3 mandatory ingredients to arrive at the exact same time.
Okay, what are they?
First, you need a surface where the blood flow is turbulent, or the smooth endothelial lining is already damaged. Think of a healthy valve like Teflon. Bacteria just slide off. But a damaged valve is like Velcro.
Ah, Teflon versus Velcro. That makes sense.
Second, you actually need bacteria or sometimes fungi circulating in the blood.
Which, wait, isn't supposed to be there, right? Blood is generally sterile.
Right, but transient bacteremia happens way more than you'd think. And that brings us to the third ingredient, time and stickiness.
Stickiness.
Yeah, once the bacteria snag on that Velcro patch of damaged valve,
Yeah.
they need to quickly be walled off by a fibrin platelet clot. The body actually tries to heal the damaged valve by sending clotting factors, but it accidentally builds a protective shield over the bacteria.
Hiding them from the immune system's white blood cells.
Exactly.
It's like the bacteria hijack the body's own repair spackle to build a bunker.
That is exactly what happens. To make this concrete, let's look at what the texts call the classic subacute case. Imagine someone who has a bicuspid aortic valve.
Which is a congenital issue where the valve has two flaps instead of three, right?
Yes, or maybe they had rheumatic fever as a kid, which left a valve slightly scarred. The blood flow around that valve isn't smooth, it's turbulent and swirling. Then they go in for a routine dental cleaning.
And that dental scraping releases normal mouth flora, specifically a group called Viridans streptococci, into the bloodstream.
Right, so they have the Velcro valve and now they have the bacteria in the blood.
The perfect storm.
The bacteria see that turbulent area, the fibrin shield forms, and they start to slowly multiply. Weeks later, that patient develops a low-grade fever, mysterious fatigue, weight loss, and the doctor hears a brand new heart murmur.
Because that growing vegetation is physically altering the acoustics of how the blood flows through the valve. But, here is where my mind gets completely blown by the history of this.
Oh, the dental antibiotics.
Yes, you hear about people getting antibiotics before they go to the dentist all the time. It was a global standard of care for decades to protect against exactly this scenario. But in 2007, the American Heart Association drastically reversed course on that.
This raises an important question and introduces what we call the antibiotic prophylaxis pendulum. It is one of the most fascinating debates in modern cardiology.
Why did it swing back?
Well, for a long time, the logic was ironclad. If mouth bugs cause endocarditis on damaged valves, we should kill the mouth bugs before the dentist even touches the teeth. Plausible logic.
Super plausible.
But when researchers actually looked at the data, they realized that everyday activities, like just chewing a tough piece of steak or aggressively brushing your teeth, cause way more cumulative bacteria to enter your blood over a lifetime than a single biannual visit to the dentist.
Wow. So we were giving out millions of doses of antibiotics for a single dental visit, completely ignoring the fact that the person was showering their bloodstream with bacteria every time they ate lunch.
Right. And taking it a step further, no randomized controlled trial had ever actually proven that handing out those antibiotics prevented endocarditis.
Wait, really? Never.
Never proven. The AHA realized the risk of creating antibiotic-resistant superbugs was far worse than the unproven benefit. So today, they only recommend it for the absolute highest-risk patients, like someone who already has a prosthetic valve or has survived endocarditis before.
I love that. It's a perfect example of evidence-based medicine forcing itself to challenge its own core assumptions. Now, speaking of prosthetic valves, the sources highlight that those cases involve a totally different cast of characters. We aren't talking about mouth bugs anymore.
No, if a patient has an artificial valve, the landscape completely changes. We see low-virulent skin bugs, like Staphylococcus epidermidis.
Which usually isn't that dangerous, right?
Exactly. On a normal native heart valve, this bug wouldn't stand a chance. But artificial surfaces don't have an immune system. So the bacteria land on the metal or the bioprosthetic material, and they build what is known as a biofilm.
The text described this as a slimy polysaccharide matrix. But what does that actually mean mechanically? Like, how does slime defeat modern medicine?
Imagine wrapping the bacterial colony in an impenetrable layer of microscopic silicone. This slime physically repels large molecules, which means the heavy artillery of the immune system, the white blood cells, literally slide off it.
Oh, wow.
Yeah, even powerful intravenous antibiotics can barely penetrate the matrix. It's why prosthetic valve endocarditis is so terrifying. Often, drugs alone cannot cure it.
So what do?
The surgeon physically has to go back in, crack the chest, and cut the infected slimy hardware out of the heart.
That is wild. The bacteria are using physical structural engineering to beat chemical medicine. So, okay, we know how these vegetations form, but what happens when pieces of that bunker break off? Because the sources emphasize that anatomy is destiny here.
Anatomy determines the symptoms entirely. Let's look at intravenous drug use. This population is incredibly vulnerable to endocarditis, but the mechanism is totally different than the dental patient.
How so?
When someone injects a drug, they are often injecting a highly virulent bacteria directly from the skin, usually Staphylococcus aureus, straight into a vein.
And if you follow the plumbing, veins carry blood back to the right side of the heart first.
Exactly. The blood dumps into the right atrium, and the very first doorway it hits is the tricuspid valve.
And this is where the anatomical logic is just brilliant. If that tricuspid valve gets infected and a clump of that infected vegetation breaks off, where does it go?
You can just trace the path.
Right. It doesn't go up to the brain to cause a stroke. It doesn't go down to the spleen. The right side of the heart has one job: pump blood straight to the lungs to get oxygen. So that infected clump shoots into the pulmonary artery, lodges in the lung tissue, and causes multiple small lung abscesses.
You nailed it. You don't have to memorize a random, disconnected list of symptoms. If the patient has right-sided endocarditis, they will present with pneumonia-like symptoms, coughing up blood, chest pain.
Because it all went to the lungs.
Exactly. But if they have left-sided endocarditis, meaning the mitral or aortic valve, that debris shoots out to the body, causing strokes, kidney damage, or vascular issues in the limbs. You just follow the plumbing.
There is also a major misconception here that I want to clear up. We mentioned murmurs earlier. A lot of people assume that if you have endocarditis, you definitely have a loud, terrifying heart murmur.
That is a very dangerous clinical pitfall. Yes, left-sided vegetations often create turbulent murmurs. But early on, or particularly in that right-sided tricuspid endocarditis we just talked about, there might be absolutely no audible murmur at all until the valve is nearly chewed to pieces.
Wow.
Yeah, you cannot rely on a stethoscope alone to rule out a heart infection.
So that covers the devastating inside job. Now let's move outside to the reactive sac pericarditis. We are ditching the internal plumbing and looking at the engine's casing. If this isn't a bacterial colony building a bunker, what is triggering the sac to swell up?
The triggers are diverse, but they all share a common pathway of provoking extreme inflammation. As we mentioned, viruses like Coxsackie B and enteroviruses are frequent culprits.
Just a standard viral infection.
Right. But it can also happen mechanically. For instance, in severe kidney failure, a condition called uremia occurs. Toxins build up in the blood, and those toxins essentially bathe the pericardial sac, irritating into swelling. Cancer, radiation therapy, and autoimmune conditions can do the same thing.
The sources are very specific about what this feels like for the patient. The chest pain isn't just a general heavy ache like a classic heart attack. It has a mechanical logic to it.
The pain is sharp, and it predictably worsens when the patient takes a deep breath in or when they lie completely flat.
Let's break down why. When you breathe in, your diaphragm drops down to expand your lungs. Since the pericardial sac is tethered near there, that drop literally tugs on the inflamed, swollen sac, stretching the raw tissue.
Exactly. And, conversely, if the patient sits up and leans forward, the pain often improves. Gravity and position pull the heart slightly forward, creating a tiny bit of space and relieving the tension between the inflamed layers of the sac.
And doctors can actually hear this inflammation, which is fascinating. The physical exam reveals a pericardial friction rub. The notes describe it as a scratchy, three-component sound. It sounds like walking on dry snow.
Walking on dry snow is a great analogy. To understand the three components, you have to think about how the heart moves. The heart isn't just one simple squeeze. First, the upper chambers. The atria squeeze blood downward. That's atrial systole. Then the massive lower chambers, the ventricles, contract violently to pump blood out to the body. That's ventricular systole. Finally, the whole heart relaxes and expands to fill with blood again. Early diastole.
So 3 distinct mechanical movements happening in a fraction of a second.
And with a healthy sac, those movements glide silently on that lubricating fluid. But in pericarditis, that fluid is gone or displaced by swollen, roughened serosal surfaces.
It's dry snow.
Yes. So with every single heartbeat, you hear a scratch when the atria squeeze, a louder scratch when the ventricles pump, and a final scratch when the heart relaxes. It is literally the sound of raw tissue grating on raw tissue.
Okay, here's where it gets really interesting. What happens if this inflamed sac doesn't just stay dry and scratchy, but starts rapidly filling up with inflammatory fluid? The heart is trapped inside a fibrous bag that doesn't stretch very well. If that bag fills with water,
you reach the mechanical endpoint we fear most, cardiac tamponade. If the fluid builds up faster than the pericardial sac can slowly stretch to accommodate it, pressure skyrockets around the heart. The engine casing is squeezing so tightly that the heart physically cannot expand to fill with blood between beats.
It's being crushed by its own protective armor.
Clinically, this presents as Beck's triad. The blood pressure plummets because the heart can't fill, so it has nothing to pump out. The neck veins distend and bulge because all the blood trying to get into the heart is backing up into a traffic jam in the venous system.
And the third part.
The heart sounds become faint and muffled because you are trying to listen to them through a thick layer of fluid.
The sources also mention a diagnostic sign called pulsus paradoxus. It sounds like a Christopher Nolan movie, but the physiology behind it is genius. It's an exaggerated drop in systolic blood pressure, like more than 10 millimeters of mercury, when the patient takes a breath in. But why would breathing in cause your blood pressure to tank?
To understand this, you have to picture the heart trapped inside that tight, unyielding box of fluid. Normally, when you take a deep breath in, the negative pressure in your chest pulls extra blood into the right side of your heart.
Okay, pulling blood in.
In a healthy person, the right ventricle just expands outward slightly to handle that extra volume.
But in tamponade, the right ventricle can't extend outward because the fluid in the sac is pushing back with immense force.
Exactly. It hits a literal wall.
Mm-hmm.
But that extra blood is still rushing in. So since the right ventricle cannot expand outward, it has no choice but to expand inward. It violently pushes the wall, dividing the heart, the septum, into the left ventricle's territory.
Oh, wow. So the right side of the heart essentially crushes the left side of the heart.
It bows the septum over, shrinking the left ventricle. And since the left ventricle is the chamber responsible for pumping blood out to the entire body, it now has less room to fill. It pumps out less blood, and boom, your systemic blood pressure drops exactly when you inhale.
That is just breathtaking physiological detective work. The right side's suffocating the left side because they are locked in a cage. Knowing how intricate these mechanisms are, the biofilm bunkers on the inside, the fluid pressure on the outside, how did doctors historically figure all this out without MRI machines or echocardiograms?
Well, we have to look back to the medical pioneers who were operating in an absolute diagnostic vacuum. Take Sir William Osler in 1885.
The father of modern medicine.
Often called that, yeah. Osler synthesized autopsy data to describe what he termed malignant endocarditis. He had no imaging. He diagnosed it entirely by clinical gestalt, piecing together physical clues. He looked for a new murmur, an unexplained fever, and strange immunological clues, like the painful raised nodules on the pads of fingers and toes that we now call Osler nodes.
These nodes are essentially microemboli, right? Tiny clumps of the vegetation mixed with immune complexes that break off and lodge in the small blood vessels of the hands.
Right. And at a grim twist of fate, the historical texts suggest Osler himself might have died in 1919 from complications of the flu, combined with what was likely a subacute bacterial endocarditis.
A tragic irony for the man who mapped the disease. But his clinical observations were foundational.
They were. Later, in the early 1900s, a physician named Emanuel Liebman refined this by distinguishing the rapid acute versions from the slower subacute versions. And crucially, in 1924, Liebman teamed up with Benjamin Sachs to discover something revolutionary, Liebman-Sachs endocarditis in patients with the autoimmune disease lupus.
This is a huge turning point in the notes. Why was discovering vegetations in lupus patients such a big deal?
Because it proved that you could get vegetations on your heart valves purely from autoimmune inflammation. There were absolutely zero bacteria involved.
Zero bugs.
None. The heart tissue was just responding to an internal immune system attack, proving that endocarditis was a pattern of tissue response, not exclusively a bacterial infection.
But as medicine advanced, Osler's clinical vibes and bedside observations weren't enough. By 1994, the diagnostic rulebook shifted massively with the introduction of the Duke criteria.
The Duke criteria formalized the diagnosis, replacing guesswork with hard, reproducible data. It required major criteria like multiple positive blood cultures grown in a lab and echocardiogram images literally showing the vegetation flapping on the valve.
But the sources show they had to keep updating these rules, modifying them in 2000 and doing a massive revision as recently as 2023 to add CT and PT scans. Why did they have to keep moving the goalposts?
What's fascinating here is that it wasn't just because cameras got better. It was to account for a frustrating phenomenon called culture-negative endocarditis. A meaningful minority of endocarditis cases yield absolutely no bacterial growth in standard lab Petri dishes.
Because they're dealing with what the notes call sneaky organisms. We're talking about the HA-seat group of bacteria or pathogens like Coxiella burnettii, which causes Q fever and is linked to livestock.
Yeah, or Bartonella, which comes from cat scratches or lice.
Right, these organisms are incredibly fastidious.
They refuse to grow on normal lab agar. They often need specific cell cultures or prolonged incubation times. Today, to find them, we can't wait weeks for a culture. We have to use molecular DNA testing like PCR or serology to prove they are in the blood. The Duke criteria had to evolve to include genetic testing because the bugs were evading the old methods.
While the definition of endocarditis was expanding to catch these stealthy bugs, the sources mention that a classic form of pericarditis has actually been quietly disappearing from hospitals. In 1956, Paul Dressler described Dressler syndrome.
Dressler syndrome is an autoimmune pericarditis that happens weeks after a major heart attack. The immune system basically gets confused by the massive amount of dead heart tissue and mounts a delayed attack against the patient's own pericardial sac.
But the texts say there's an active debate on whether medical school should even bother teaching Dressler syndrome anymore.
Because modern cardiology got almost too good at its job. Today, if you have a heart attack, paramedics and cardiologists use rapid reperfusion therapy, like sliding a catheter in and deploying a stent to open the blocked pipe within minutes. We limit the heart muscle damage so quickly that the massive necrotic tissue death required to trigger that delayed immune confusion rarely happens anymore. We fixed the mechanical plumbing problem so efficiently that we basically eradicated the downstream inflammatory disease. That is incredible. So we've covered the physics, the history, the diagnostic evolution, but let's bring this into the modern context. How do these two diseases impact the medical landscape today? Because endocarditis isn't going away. In fact, it's rising in high-income countries.
It is, and it's driven by modern medical and societal shifts. We have the opioid epidemic driving massive spikes in intravenous drug use, leading to virulent right-sided Staphylococcus aureus infections. We also have an aging population receiving more pacemakers, more prosthetic valves, and requiring more dialysis catheters. Every piece of plastic or metal we put into the vascular system is a potential landing pad for a biofilm. We are essentially installing more doorways for bacteria to enter the bloodstream and giving them more artificial surfaces to hide on. And yet, on a global scale, the classic cause of damaged valves rheumatic heart disease from untreated strep throat tells a very different story.
Rheumatic heart disease is mostly a solved problem in wealthy nations, thanks to widespread penicillin use, but it remains a massive ongoing crisis in sub-Saharan Africa, South Asia, and the Pacific. Endocarditis isn't a solved disease globally, it's a geographically polarized one.
And pericarditis, that term absolutely invaded the mainstream recently due to rare reports of it following mRNA COVID-19 vaccination, particularly in young males. The news cycle went crazy.
It did, and that is exactly where understanding the strict pathophysiology of what we've discussed today becomes so vital.
Because there's a major myth out there that getting pericarditis is basically the same as suffering a heart attack.
It is a total clinical hazard to conflate the two. The chest pain feels terrifyingly similar to the patient, but the mechanism is entirely different. You treat a heart attack with emergency stents and blood thinners.
Right.
But you treat viral or vaccine-related pericarditis with simple anti-inflammatories, like high-dose NSAIDs or colchicine. And an EKG instantly tells them apart. A heart attack shows localized electrical changes corresponding to the blocked artery, while pericarditis shows diffuse, widespread elevation across the entire EKG because the whole sac is irritated.
So what does this all mean? When the vaccine reports came out, understanding these first principles, knowing what structure is inflamed, and by what exact mechanism allowed public health officials to reason through the controversy.
Exactly.
They could look at the data, see a rare, reactive, and usually transient inflammation of the outer sac, and not panic by confusing it with a permanent structural destruction of the heart muscle or valves.
Knowledge of the mechanism is the ultimate antidote to panic. When you understand the physics of the disease, you can accurately evaluate the real-world risk.
So to recap the core difference we've unpacked today, endocarditis infects a structural surface, actively chewing through and destroying the heart's valves from the inside like grit in an engine. Pericarditis inflames a reactive sac on the outside, which can swell with fluid and mechanically restrict the heart from filling. Inside job versus outside reaction.
Perfect summary. And if we trace these mechanisms to where medicine is heading next, there's a provocative challenge here for biomedical engineering. We talked about how skin organisms like Staphylococcus epidermidis land on artificial valves and create impenetrable, drug-resistant slime bunkers.
The ultimate shield.
Exactly.
Yeah.
So the future isn't just about throwing stronger, more toxic antibiotics at the blood. The question is, how can materials engineers redesign the microscopic surface architecture of all our implants, from pacemakers to artificial joints?
If the bacteria are using physics to stick to the Velcro, we need to use physics to bounce them off. Maybe engineering surfaces at the nanoscale so that it is physically impossible for a single bacterium to anchor itself in the first place? A frictionless surface.
Bypassing the immune system entirely by making the materials inherently repellent. It's a completely new frontier in medicine.
Thank you for joining us for this deep dive. Next time you think of the heart, remember, it's not just a pump with pipes that can clog sometimes. The diagnosis requires looking for a battlefield where the structures themselves are under siege. Keep questioning the mechanisms, and we'll see you next time.